conversation today. So I want to say not just okay for questions, but I very much welcome questions and discussions. Thanks, Judith, for the invitation to talk about this paper. And thanks to Chris, who you'll see really co-leading this paper from conception. And I think there's opportunities that Chris can jump in and add some detail. But thanks for this idea, Chris, and kind of helping to facilitate to bring this together. I know Judith did an introduction, so I won't go all the way. I'm faculty at Ohio University in Athens, Ohio, and really for many years now have been studying kind of the accountability relationships between nonprofit hospitals and their communities. Before stepping in my faculty role, I had the opportunity to work with a few health systems and really saw on the ground perspective about both challenges and opportunities of hospitals knowing their community, programming specifically for their community, and had a real interest, continue to have a real interest in the variability to that, and especially how things like health policy can play a role in what we ask of nonprofit hospitals and how maybe what's reported out publicly does or doesn't at times match what's actually happening for those within the organization and within the community. Um, Paper I'm going to talk to you about today actually comes from meeting Chris, and you might hear me say this a couple of times, but one reason I really like this paper and the project in general was Chris and I met several, 3-ish years ago, I think. And the thing we immediately knew were we each had kind of quirky data sets. And by quirky, I mean actually both of our areas of interest that we were currently working on were part of the Affordable Care Act policies that were asking hospitals to make things more publicly accessible and to be more knowledgeable about populations and communities that they served. Sorry, I see a chat. I'm just okay. Um, and it means that these things were out there on the internet mainly, but for researchers like us, having something that is a web page or a PDF means there has to be quite a bit of effort to go through that we could take this from that type of document or report and be able to systematically analyze things. And so what's really interesting is both Chris and I were going through these difficult, long processes of taking publicly available information and putting them into formats that could be asked questions and a lot of different questions. When Chris and I met, I don't think the plan was, I hadn't expected we'd be like, well, we've each got kind of a weird data set. Could we smush them together into one thing? But that's exactly what I'm going to talk to you about today is that is where our conversation led. And we took on a year or so long project of first the difficulty of the uniqueness of these data sets and how they do and don't come together, but then also once we put them together, are there some unique questions we can ask? And we do believe we found a question that hasn't been analyzed, likely because of the data limitations to it. And so that's what I'll present. I also want to recognize the other contributors to this. So I've already mentioned Chris. Tatiana Santos is faculty at Tulane University and is really starting her career there with a great focus on kind of the tax exempt nature of nonprofit hospitals and the financial reporting that they do. And then Marianne Jacobs also contributed. She was a research associate who was working for me here at Ohio University at the time. But let's get into things. So I don't want to make assumptions. I think if you're coming to lunch opportunities like this is probably not new information for you. I risk going off the deep end into a history again that maybe is well known, but it is what I have been thinking about for about the last decade. But there's an agreement, a handshake, a bargain between the US federal government and nonprofit hospitals that about 60% of our hospitals in the United States are nonprofit. And many decades ago, it was said there are benefits to being classified as a nonprofit in that you don't pay most of the taxes other organizations pay. But in return for that, we are going to ask that you give back to your community. The evolution of this, again, is well documented and something I could talk about, but early on, this was through charity care, that these hospitals had some expectation that those in need in their community would have access to healthcare, come to be through the emergency room mostly, and through not billing and collecting from some portion of patients. And charity care, while it's one of the earliest points in history, is still the largest percent that hospitals write about in their tax reports as being their community benefit. In 2008 or so, the idea of community benefit legally, definitionally, was expanded to go beyond hospital charity care and include a lot of really interesting categories, some clinical, some non-clinical, and the non-clinical ones were the relatively new ones that hospitals could classify programming they were doing that could be considered community health improvements. They could classify education and research they were doing through their institution. There's even a category of community building, which is a real non-healthcare but more socioeconomic supports that hospitals can provide to communities. And that one is listed now in an optional reporting category. But all of this are different health investments that we can see. And many have reported from a lens of our hospitals meeting their nonprofit expectations? Are they investing at or near the benefit they receive by not paying taxes? And so a number that's reported is, each year about 28 billion tax revenue is not collected from these nonprofit hospitals. And so if we think that that is money that could be used to improve the health of the community, is it going in that direction, or is it going other places in the healthcare system or organization? And this is where we get to the two unique data sets. So I and a colleague here at Ohio University, in about 2017, had this idea that with the Affordable Care Act, one of the new provisions was that every 3 years, all nonprofit hospitals would be required to do a community health needs assessment. Again, another deep end I could go off of, but I'll hold back here because it's not exactly relevant. But there are specifics as to how you get input from the community, what the process looks like, how you define your community. But every 3 years, nonprofit hospitals have to go through the process of a community health needs assessment. And this process should land at a set of 3 to 5 community health needs that the hospital will prioritize. And the way we know these needs are prioritized is there is a required corresponding implementation plan that must be created. And so this document that comes after is supposed to be a narrative in the way that hospitals are going to do something about these community needs they are now aware of. These documents are highly variable in what is included in them, how they are laid out, their quality. Some documents have lots of detail. They show evidence-based strategies, they have a budget, they have a timeline, they've reflected on their efforts from the previous cycle. Most of the documents don't include all of those things, and some don't include any of those things. Some are vague hand waves to, we're already doing this program, we're going to continue to do this program. So it's really, really variable. Now, it is important. The requirement is that these documents are publicly available. It is important to note that different organizations have different levels of resources, both financial, staffing, dedicated time to do something like this. And some organizations hire consultants to do this process for them entirely, which could produce very impressive documents. We just hope, maybe being disconnected from the process, they're still taking in the information from the process and not disconnected from all of the lessons that would come from this process. It's where Chris should have an opportunity today to talk a little bit more about his data set, but the Affordable Care Act also had some regulations around something that's existed for quite a while in the way of financial assistance policies. So if somebody is lacking health insurance, going to pay significant money out of pocket, should our hospitals charge them gross charges that are in the charge master? And I think everyone, generally, the Affordable Care Act including, agrees that's not really fair because those charges are set knowing most patients have an insurance company in the relationship who will negotiate down those rates. So if they're not going to charge what's in the charge master, what should they charge? What is the threshold to qualify for this financial assistance? How do you know you're eligible and enact it? And all of these things. And so Chris and others on his side went through the hard work of actually reading these policies, and most of us don't like reading the fine print, but took the time to read these policies and code them, and especially appreciate Chris's attention to not just a snapshot of what these are, but trying to measure from one point in time to the next. Are they staying the same? Are they getting more generous? Language is kind of hard here, but are they getting more generous as in they've allowed new people eligible or they're giving greater discount? And so that was Chris's side of this data set, is he had these hospitals that he had understood in detail their financial assistance policies and what direction they were moving. So one thing I knew from doing two waves of hospitals' health needs assessments and implementation plan coding, we had a data set of a 20% random sample of all US nonprofit hospitals. Every state was represented in it. We published a number of papers out of this data set. And so, of course, one of the obvious ones to go first is what are communities and hospitals saying are their top health needs? Mental behavioral health is the most frequent need in these documents across the whole United States. In fact, it's something like 86% of the nonprofit hospitals we looked at's documents put mental behavioral health as one of their top 5 needs. So that's an interesting lesson about health in the United States right now. But access is right there. Number 3 was access as a top health need. And so our question here, and the way we could use these two data sets that aren't easy to get to, was if access to care is a top community priority, do hospitals actually expand their policies, allowing for greater access? So what you might expect, do a community health needs assessment, receive feedback from your community that access to care is one of the top needs. You prioritize this need by creating a strategy around it. And crossing to the other side, one way we could improve access would be by making financial assistance policies more available, allowing more people on, giving greater discounts. Charity care, financial assistance is one of the greatest tools that hospitals have in their control around access to health services. So our data set ended up being, starting from Chris's of analyzing financial assistance policies, we had 170 large US tax-exempt hospitals. The financial assistance policies spanned the period of 2021 to 2023. Of these 170 hospitals, some of them were already in our existing CHNA and implementation plan data set. Many of them weren't. And so we actually went and, knowing how we now know how to process and code these documents, we went and found the ones that weren't already in our 20% random sample and brought them in. But we matched these hospitals that were in Chris's financial assistance policy database by pulling their CHNA implementation plans. These documents ranged the years 2018 to 2023 because it's an every 3 years and not every hospital's on the exact same cycle. This was the date of those documents. And we reviewed them for whether access to care was prioritized. And when access to care was one of the top 5 health needs, we read the implementation plan to see what strategies the hospitals were proposing to address this gap in access to care that was identified in their community. On Chris's side, and this is where he could talk, and in Q&A will be much more knowledgeable. And again, language is actually an interesting thing here, but we really had these categories of the financial assistance policy in this time period moved in a direction where it was more generous, broader eligibility, covered more services, an easier process to navigate it. Maybe the change was unclear, or it was unclear if there even was a change to their financial assistance policies. So updates that didn't really shift the meaning of the policy. And in some cases, hospitals' policies were updated in ways that they were more restrictive, that there were maybe tighter income limits or narrower services. Overall, more restrictive process. And as I said, we know this from our national data set of nonprofit hospitals and CHNAs that access is one of the needs we see most frequently. And so 68% of these hospitals, 103 of them, did have access as one of their five prioritized needs. 40% took that and turned it into an implementation plan that we could identify in that document. So we had 60 different strategies that nonprofit hospitals, well, each one could actually have multiple strategies, but 60 of the hospitals have strategies with a plan to address access to need or need for the access to care. However, when I gave you that nice three boxes of how you might expect things to flow for at least some of the hospitals, that's not what we found here. Access being prioritized, even having a strategy to improve access to care in the community did not correspond to a change in the financial assistance policy in a way that it would be classified as more generous. If you look here, we've got those who prioritized access on the bottom, those who did not prioritize access at the top, and you can just tell by looking at this graph that they're about the same. There's not a difference between these two groups, and so it was not surprising that this was not a statistically significant finding, that rather you prioritized access or didn't, the distribution of hospitals on the financial assistance policy coding was largely the same for both. And in fact, you can see the more restrictive group, while not significant, is actually a larger portion of the group of hospitals who did prioritize access as one of their top needs. So what did hospitals do? If when they prioritized access and created strategies, it wasn't to turn to their financial assistance policy and ask if this is working or if it could change, they did do some innovative things, some helpful things potentially. The most frequent thing we saw in hospitals' implementation plans was creating or strengthening a patient navigator system or insurance enrollment assistance for people in the community. So connecting people to maybe the information they need to access available services. They didn't ignore their financial assistance policy. 25 of our hospitals, 42%, did reference that they have a financial assistance policy when talking about access. So they didn't directly say they were going to change it, but they said it exists. And then there were other things. We read about some interesting services to connect people with prescription drugs that they need. We read some strategies around increasing transportation to health services in the community. And then a number of strategies were actually condition specific. One I remember in detail was around connecting people for cancer services and how you might create a greater continuum of care for a population with a certain cancer diagnosis. To our main research question, though, down here at the bottom, 0 hospitals directly engaged with the idea of expanding their financial assistance eligibility threshold, for example, when they were considering ways to meet the need of access to care. So that's this slide. 0 actually directly went to consideration of their financial assistance when thinking about how to address access as a top need within their community. So that's what we know from our data. Now is where we try to make connections and put meaning on this. And so some of this, this is a place where, and you'll see future research directions. This is definitely the place where checking in with people who are working at organizations or in communities could offer some insight. But from the outside, looking at this data, thinking about why this might be, it seems to us, and I've anecdotally heard other places, that organizations sometimes work in silos. And the group of people who are charged with something like a health needs assessment and implementation strategy programming might not be the same group of people who are setting, reviewing financial assistance policies. And especially we kind of have maybe and again, I know this takes different shapes, so this one model is probably not true, but you probably have a team in either a community improvement, community benefit, or community programming office who are tasked with leading the CHNA and implementation plan process. And then you often have the finance department overseeing the financial assistance policy, meeting legal requirements of it, making updates to it. And we certainly multiple times during this project said, do these two groups talk? And that's a little extreme. Of course they talk, but are there formal channels of communication when creating implementation strategies, for example? Are there formal channels of communication where the finance team could give input and offer ideas? Or could the community health improvement office suggest to the financial team that maybe the financial assistance policy should be looked at and could be listed as a strategy? Um, and then I mentioned charity care is by far the greatest community benefit expense to nonprofit hospitals in the United States. So, how these policies are set, even changing thresholds a little bit, are significant dollars to this organization. And so, while other community type programming could have costs, this is probably one of the bigger areas that could cost the organization in a single year, for example, by making a change. So I'm sure there has to be careful examination of how a tweak to this policy could result in finances for the organization. Our finding fits well with many recently published studies, some of our own, some outside, but we do see that while most of the nonprofit hospitals are meeting the requirement in the United States of doing this process, making these documents publicly available, we're not always seeing the connection to practice that we might expect. And then Chris and his team have looked at in a couple of different ways these details on financial assistance policy directly. So the last paper here, many nonprofit hospitals, if we are measuring dollar to dollar, don't make community investments that are equal to their tax-exempt status, even, for example. So we are fitting in a body of literature that has shown some disconnect in the intention of these policies and the outcome, or even in the process inside of organizations themselves. So, what are the implications? What could be done? I already mentioned, so I'll say quickly the top of this list is we could bridge the silos. We should be sure the right people are at the table who, what's within their purview of the organization could have an impact on the community and population level health outcomes. They should be at the table and having these discussions. Financial assistance policy should absolutely be seen as one of the strategies that could drive population health. When people go without needed care, we know how that contributes, importantly, to individual health outcomes, but it also contributes to community level health outcomes and to cost of the overall healthcare system. And so if we're viewing financial assistance policies as only checking a regulatory box or as only a financial practice, we're probably not giving it the weight it needs within the organization. Income limits that we set should be matched to the population that exists. And so are we able to meet the needs of the population that the hospital serves? And then, like I said, we did see some strategies. It's not that nothing came back, but if we're going to do things like patient navigators and give people information, that only goes so far. If our eligibility standards, for example, are not really generous enough to provide assistance in the end. So, from an accountability standpoint, there's a lot of potential in having these documents have the requirement to be made publicly available. However, I think it was quickly learned, and I can speak more on the CHNA side, I feel like it was more quickly learned that if there were any check done at all, that check is on, does the website have the document? Yes, no. And that's where compliance ends. And I just want to say there's real potential here for transparency and accountability by having hospitals do this process. And for those who work within healthcare organizations doing this, the work is meaningful to them. It is taking their time and resources. And I don't think they're trying to do something that doesn't hold much weight or doesn't produce change. They just don't always have the resources and tools to follow through with things. Um, there's some question even here if the IRS is the right part of the federal government to be setting these compliance type standards. Like, yes, we have tied all of this to the nonprofit concept, and we can ask more of nonprofit hospitals than other types of hospitals because that standard exists. But is the IRS in the business of understanding what community programming is effective and what is not? Do they even have time, resources, or interest in seeing if any healthcare organization followed through with any of these processes? Or do they just check if it's available on the web? And I don't think they actually even check if it's available on the website, to be honest. But that is the way the compliance is listed. So we have a foundation here to increase transparency and accountability. We have really good ideas, but to some extent, actually following through with these ideas is voluntary at this point. And so good news would be to take this further. You don't have to invent something new, just tweak a system that is already in place. But not sure there is much of an appetite at this time to tweak that system. And that's what I think will be interesting to watch. So the work we did leaves open room for us or others to take this further. Just some things off the top of my head and putting this together of where next steps could be. Do financial assistance policy, does their generosity actually change utilization of the services? Are people avoiding care out of fear of financial debt or consequences? And if hospitals make their policy eligibility more generous, for example, um, does that change behavior in seeking health services? We've talked today only about the federal landscape of policy. This is where Tatiana on our team is an expert, is understanding state level policy. And she's looked at many states. Oregon, in fact, is where she's been spending a lot of her attention recently. Um, and Oregon is an example of a state that has recently made some significant changes at the state level to these, not doing away with the federal, but adding a layer on top of the federal. And so, how do state level policies change this picture? And I think there's a lot of room for work to be done there. Um, if we could go inside organizations and not just look at the data on the outside, how do teams within hospitals collaborate on these processes? Am I wrong in the assumption that maybe we have two different teams working on a process? Do they work together and face other barriers or limitations in putting policy forward? And then a key interest of mine um, is being aware of financial burden and that not all hospitals are resourced the same. And so if we look at smaller organizations, especially rural organizations that are struggling in many cases financially to primarily offer the services they feel their community needs, how much can we ask for them to invest in administrative process or invest in community programming? Do they have the finances even to do these types of things? How would changes affect their finances and ability to stay within the community? So that's what I have to present. Again, Chris is here too, which is great. So if you have exact questions on the financial assistance, I hope he will jump in. I know he'll jump in. I'm happy to answer any questions. Judith, I've seen there's some things in the chat. So I don't know if I
Yes.
should open
Well,
that or how you, I'll hand to you.
Yes, sure. The biggest question is in the chat is, can we make these slides available to registrants? The recording's going to be available as well, but the PDF of the slides would be fantastic if you're open to that.
Yeah,
Um,
I'll make and send to you, Judith.
that's
So.
perfect. And then I wanted to hand it off to Chris first to see if you had anything to add from your perspective on the financial assistance policy side.
Well, thanks. That was amazing, Corey. I mean, the slides are just, perfect, augmenting what you're saying. I'm glad you led the way here. Thanks for a wonderful presentation. And yeah, I'm happy to stay on and join in the conversation.
Great. Well, if you have a question, please press the raise hand button or put your question in the chat. And while you're all thinking of questions, I will take organizer privilege to ask my question first. So, from a lot of the research that we and others have done, and Dollar Four and other folks have done, part of the issue with accessing financial assistance is there's both the how generous the policy is, but also the implementation of that policy. And there's new like patient screening requirements and this kind of thing. But I was curious, to what extent did implementing, like making financial assistance easier to apply for and get, how did that ever show up in the implementation strategies of hospitals?
I'll take the implementation strategy side and then let Chris talk about some of the screenings and things. And I would say, no, the only time, because one of our very first quick passes, is there anything here,
Mm,
was to actually do a control F on a large document, so control find for variations of the word financial assistance policy. And so we did very carefully analyze any time that word came up. And the only time it ever came up was a simple reference that one exists.
mm,
We saw no language in any of our 150-ish hospitals, no language of a change being made to it. It was merely, access is a top need, and we have a financial assistance policy. But Chris, I'll let you, as far as the way you see language and financial assistance policies change or screenings for eligibility, et cetera.
Sure. And Judith, you were asking about the patient navigation in particular aspect. Did I hear that right? Or
more about like whether hospitals are changing the way they implement the financial assistance process, like making it more automatic as opposed to having this application or like getting rid of barriers and obstacles to apply.
okay, yeah, it's kind of a yeah, kind of a process navigate. Yeah, a lot of that doesn't end up in the FAPs. Um, and maybe it should, maybe I mean, it would be nice because we weren't discounting completely the idea that hospitals might think about navigation and mention that because obviously that's an aspect of all this. Um, and it would be nice to know how well how they think about this, how their staff to do it. So, for example, at my organization, I could think back a decade ago, and some of you have heard me say this when we at the in the lobby of the hospital, you could easily go and find a financial counselor to talk to, and you might be pointed that way if you were asked about this. But now that's not the case. It's all either a third party group you might have to talk to that's doing a lot of the automatic screening, or someone virtually somewhere else in the state to talk to who's not local, not in front of you to think through. That's a big difference. So it would be nice if there was more transparency about even just this navigation aspect. So hopefully that answers your question.
Mhm. So we have some questions in the chat, Corey, if you want to, would you rather look in the chat or have me read them?
Tell me if I missed one. Judith, I saw one on Medicaid expansion,
Yep.
which I think is important. Like we mentioned state policy, but Medicaid expansion states. And Chris, you'll have to help me recall here. I know we looked a few ways. I didn't put a limitations on limitations. This is a small number of hospitals. And Chris, your selection of hospitals to analyze the financial assistance, we know did skew towards hospitals that are part of health systems, for example, which is where I say we have opportunity maybe in the future for smaller rural hospitals um, to see if there are any differences. But Chris, do you remember their geographic variation and if we would have had a balance between Medicaid expansion, non-expansion, or if it would have skewed one way or the other?
The sample was designed, or the rules for it we did about 8 or so years ago, and it was and it's good geographic representation. Every state's represented, so you get it. You know, um, hospitals in every state, and but it does skew a bit towards urban safety net among the 170 hospitals. And so then I think a question was asked about expansion versus non-expansion. As you know, that sort of non-expansion is whittled down over time, and but it is capturing also this non-expansion versus expansion. Although we didn't explore that specific question in this study.
Yeah, thank you. So there was a question, and Chris, sorry, I think this may come back to you too. Have you looked at hospital financial assistance policies and compared to the growing number of hospitals that are outsourcing hospital services or departments?
Yeah, I was kind of alluding to this in my answer to Judith a minute ago. Like the procedures for this, you know, do seem to be involving more um, third party or sort of external companies, and I think that that's got to have an impact, but that's not tracked in any meaningful way that I'm aware of, and it's not something that's going to usually be listed in a policy. Now, the caveat to that is where we've, and Kelsey and I have written interested in this, where some of this is in there where they'll talk about presumptive eligibility or the screen or the partnerships with third party for some of that pooling of data. You do occasionally see that in there, and some of the major players in this, like Experian, Waystar, and others. So you can find it's just not systematic or common enough to be able to speak meaningfully to the patterns.
And then back to you, Chris, for the if you off the top of your head know the average federal poverty level. Um,
Yeah, it hasn't changed much since we've been following these. So discounted care is, I think the median's 200%, and the free income care cutoff's 200% FPL, and discounted care is 400% FPL. I think that got reported in a separate health affairs article that was looking at a bigger sample, and it's about the same.
yeah. Um, Kelsey, I'm reading your question around when it was a strategy not related to financial assistance. So when we did see strategies for access, patient navigation, transportation, the prescription drug access program we read about, those were not tied to eligibility for the financial assistance. If they were tied to any kind of eligibility, like I said, one thing that surprised me in seeing access as a community need, I just hadn't expected the number of times that might be patient population or condition specific. And maybe I'm overblowing how frequent that was. Maybe one just really stood out to me to be like, oh, that's an interesting way to take access, to talk about this one type of cancer program that you're going to increase services for that. But I did not see I did not see the other types of access programming being linked to income eligibility requirements, for example. They seem to either be broadly available to the community or more population disease specific groups had, they were designed to meet those groups' needs. Um, that sound right to you, Chris, also, as we looked at these examples?
Yes. Yeah.
Um, Katie, I see your hand if you want to go.
Thanks. Yeah. Hi, I'm Katie Byerly. I'm with Undue Medical Debt. Appreciate the presentation. It's a question that had come up for us, but I wanted to share a resource. that our team worked on alongside the Healthcare Anchor Network. We ran a cohort last year with leaders from revenue cycle and leaders from community benefit offices, brought them together in a cohort. So we had 3 health systems that participated in the cohort. And they worked on projects between them, between the revenue cycle and the community benefit leaders, sort of getting at this point that you're making, that a lot of times while financial assistance or charity care amounts are reported alongside community benefit, there's actually not a lot of collaborative work that's happening between the 2 departments. So the page that I just dropped in the chat are some of the key learnings. And one of the
Great.
things that we heard from participants of that cohort was that the relationship building was one of the most important parts, that they didn't know the people who worked in those different parts. And then there was also a lot of excitement around data sharing. So one of the big resources that came out of the cohort was looking at shared data that the 2 different groups could use, and how they could utilize that to answer different questions. So we're hoping to run another cohort cycle at the beginnings, kind of starting recruiting in the fall. And Gregory Brody, who's also on the call, is actually presenting about this cohort at the AHA Healthier Together conference that's coming up next week. So if you know anyone who's going to be there and is interested in this topic, or anyone here, we're excited to kind of keep building on this question of how to bring community benefit professionals and revenue cycle professionals together around some of these similar questions.
Yeah, thanks for sharing that and for sharing the link. I'll definitely check that out.
Anyone else have questions? I don't think not seeing any in the chat, although some really good conversation about some research and state policies. Celine, do you want to unmute and give a little update on that in California?
For sure. Yeah. Thanks, Judith. Hi, everyone. Celine Betancourt, a state policy advocate in California with the California Pan-Ethnic Health Network. Last year, with our co-sponsors, actually Blood Cancer United and Health Access California and Rising Communities in South LA, we co-sponsored AB 1312 that will go into effect next year, which is kind of our try at a pre-screening legislation that was modeled after Oregon, but obviously in the policy conversation negotiations had to kind of limit what the bill could do. But we did include a number of provisions that hopefully should provide some helpful data listening to this conversation, asking hospitals if they're going to use these third-party vendors to disclose those tools, kind of put some guardrails around how they use that. But then also encouraging the use of tools, right, to do these screenings that we're asking them to do, and trying to create a presumptive eligibility pathway for folks who are already in means-tested programs and, expand access. California has a very robust, for the most part, financial assistance laws, but we were just noticing that folks, as Judith mentioned earlier, that weren't able to access in the same way. And so a lot of great help too, also from $4 and undue medical debt and Lown. We've got a lot of great research and data to be able to show to our lawmakers, but helpful if folks at other states want to explore, also helpful to chat to kind of our experience tackling California. We have, almost 400 hospitals, and financial assistance requirements apply to both for-profit and nonprofit hospitals in California.
Great. All right, last call for questions. All right, well, thank you all so much for attending, and big thank you to Corey and Chris. Oh, wait, got in chat? Okay, we got a little announcement here in the chat. There's a presentation from Undue in Dallas for HTC. Great. And I think I put in the chat our next lunchtime paper presentation, but I'll also put here the link to our Confronting Healthcare Affordability conference, which you can get on the wait list for that if you're interested. We'll have the recording and slides available pretty soon. So thanks very much for attending, and we'll see you all next time.
Thank you, Judith. Thank you, everyone. Thanks, Chris. Bye.
See ya. Great job.